Assalamu alaikum. My name is Dr. Aksa and I'm FCPS gynecologist. Let's discuss cervical cancer. This is very key topic in the exams and this presentation will help you how to prepare topic of the cervical cancer for your clinical exams. Age group involves bimodal peak of incidence that is 30 to 40 years and 50 to 60 years. Clinical presentation of cervical cancer includes irregular vaginal bleeding, postcoital bleeding, abnormal vaginal discharge, weight loss, loss of appetite, bowel and urinary complaints. Most specific is postcoital bleeding and most common complaint is irregular vaginal bleeding. Advanced cancer is found to have altered sensorium and hiccups, likely causes uremia, renal failure because of spread of the tumor to the lateral pelvic wall. And the most common cause of death in advanced cervical cancer is renal failure. Now moving towards the risk factors that you will ask in the history of the patient includes early intercourse or early childbirth, high parity, multiple sexual partners, concomitant STDs, low socioeconomic status, smoking causes type of T squamous cells, carcinoma of the cervix, and OCPs cause adenocarcinoma of the cervix, and immune compromise that is HIV patients. Now, what are the histological types of the cervical cancer? Most common is squamous cell carcinoma that is caused by the HPV-16 and the adenocarcinoma that arise from the endocervix caused by the HPV-18 associated with OCPs use progesterone only and occurs in the young woman. Now moving towards the examination part, first we will do the journal physical examination including the vitals, look for the signs of the anemia, cachexia and the features of the renal failure. Local examination includes steroid per speculum examination. We look for any cervical growth, any necrotic patch, any fibril mass, bleeding, discharge, and ulcer. If growth is visible on the cervix, then take punch biopsy from normal and abnormal areas. If ulcerative growth seen, then take punch biopsy. If no growth seen, then go for the colposcopy. Clinical examination also includes two bimanual examination to look for the uterine size, mobility, and adnexal mass or tenderness, and the pervaginal examination to look for the local extension of the cervical cancer to see lateral fornices are free or flushed with the vagina, to feel the parametrium is thickened or nodular. As cervical cancer staging is primarily clinical, so clinical examination is very important in cervical cancer. Route of spread of the cervical cancer is local extension. Most common is lymphatic, greater than the hematogenous. Lymph nodes involved are hypogastric obturator. Hypogastric and obturator lymph nodes are the part of the internal iliac lymph nodes, paracervical, external iliac, and sacral lymph nodes. Advanced stages involve paraaortic lymph nodes, and spread to the ovaries of cervical cancer is very rare, less than 1%. Investigations include diagnostic investigations that includes colposcopy and cervical biopsy. Colposcopy is done if there is no growth visible on the cervix on clinical examination. And cervical biopsy, there are two types of the cervical biopsies. Punch biopsy, small that in punch biopsy we take small biopsy from the surface, and the leaf or the cone biopsy, large sample taken, also therapeutic for precancerous lesions. Now, staging investigations, once the diagnosis is confirmed that it's cervical cancer, we will do the staging investigations. As I have already told you, cervical cancer staging is primarily clinical. So, pelvic examination under anesthesia we will do if the patient is not comfortable without anesthesia. We will advise MRI pelvis to look for the tumor size, parametrial involvement, and do local staging. CT abdomen, pelvis, and chest. PET-CT used for advanced diseases and treatment planning. Cystoscopy and proctoscopy is done if bladder or rectum involvement is suspected. Blood tests are done to assess overall health and organ function that includes CBC, liver function, and renal function test. Now moving towards the staging. As spread of the cervical cancer occurs by direct extension, so stage 1 is limited to the cervix and stage 2, that is 2A, is limited to the upper two-third of the vagina. 2A1 is size of the growth less than 4 centimeter. 2A2 is size of the growth cervical growth equal to or greater than 4 centimeter. And 2B is parametrium but not to the lateral pelvic wall. 3A is lower one-third of the vagina, and 3B is parametrium up to the lateral pelvic wall. When the extension occurs up to the lateral pelvic wall, there it involves ureters or the kidneys. So when you see the report of the MRI or the CT scan where the kidneys or the ureters are involved, then this is stage 3B. 3C is pelvic and paraaortic lymph nodes, 4A is bladder and rectum, and 4B is distal meds, most common lungs, and superficial inguinal lymph nodes. Superficial inguinal lymph nodes are in 4B. So, stage 1, as I already told you, is limited to the cervix. 1A is microinvasive disease. It means there is no visible growth seen on the cervix. It is diagnosed on LEEP or conization. 1A1 is depth of the invasion less than 3 mm, and 1A2 is depth of the invasion 3 to 5 mm. 1B is depth of the invasion greater than 5 mm, and 1B is invasive carcinoma. It means visible growth on the cervix. When you see the visible growth on the cervix, you will direct label it stage 1B, but with the depth of invasion greater than 5 mm. It is diagnosed by the punch biopsy. 1B1 is size of the growth less than 2 cm. 1B2 size of the growth 2 to 4 cm. 1B3 size of the growth greater than or equal to 4 cm. Now the treatment plan. For the cervical cancer, surgery and radiotherapy both are equally effective, but we prefer surgery. Why? Because in this tumor is out, ovaries can be preserved. Cervical cancer treatment primary is radiotherapy or chemoradiation, not only chemotherapy. Is in the chemoradiation, chemo part is given to make it as a sensitizer. Size of the growth greater than 4 centimeter. That includes 1B3, 2A2, 2B and beyond. For all these, when the size of the growth greater than 4 centimeter, treatment of the choice is chemoradiation. Also, general measures will take in this healthy lifestyle and tell the patient to avoid smoking. Okay. Now discuss the stage-wise treatment. First, there are three columns. Second, middle column is stage, and the first column is when family is not completed, what the treatment plan, and when the family is completed, what will be the treatment plan. So when the stage is 1A1 and there is no lymphovascular space invasion, then conization can be advised. And if the family is completed, then go for the simple hysterectomy. If the stage is 1A1 and lymphovascular space invasion and 1A2 stage and family is not completed, then go for the radical trachelectomy. And if the family is completed, then go for the Wertheim's hysterectomy plus pelvic lymph node dissection. Now, if the invasive CA limited to the cervix and size less than 4 centimeter, then family not completed, then go for radical trachelectomy with abdomino-ischemic cervical cerclage. And if the family is completed, then go for radical hysterectomy plus pelvic lymph node dissection. Now, what is the post-operative management? Post-operative management is patient is high risk if 3 M's are positive. What are the 3 M's? That is, if margins of the specimen are positive, if meds to the lymph nodes are positive, if parametrium is positive. If any of the above is positive, then advise chemoradiation to the patient. For the chemo, drug of choice is cisplatin, and for the radiotherapy, that is external beam radiation therapy, teletherapy, intracavitary brachytherapy. If the recurrence of the disease occurs and the recurrence is local, pelvic, and primary surgery is done, then go for the chemoradiation. What is the follow-up of the cervical cancer patient is 3 to 6 months follow-up for first 2 years and then 6 to 12 months follow-up for the following 3 to 5 years. What is radical trachelectomy? It is done by the oncosurgeon. It is fertility sparing surgery. In this, cervix is removed, parametrium is removed, pelvic lymph nodes are removed, and rest of the body of the uterus is sutured with vagina. Thank you. If you like this presentation, do subscribe, like, and share.